The first annual Riordan IVC and Cancer Symposium proudly presents IVC, chemotherapy, and radiation. Are they compatible? Your presenter, Glen Hyland, MD.
Dr. Glen Hyland, trained at Mayo's as an oncologist. You were in internal medicine, then oncology, and was in practice and wanted to learn more about radiation oncology and went back to Mayo's. Maybe you didn't go to Mayo's in the first one? Northwestern for oncology, Mayo's for radiation. He really is a radiation oncologist. I can attest to it. We enjoy having Glen here because when we have our patient care conferences, he brings a tremendous amount of knowledge in terms of helping us understand the various chemotherapies and radiation strategies that these patients are undergoing. But he's bridged that gap, and he has seen the value of intravenous vitamin C and other nutritional therapies. But today he's going to take on a rather difficult topic of where does IV vitamin C fit with chemotherapy and radiation? Are they compatible? Glen Hyland.
It's okay? Well, hello. Actually, a lot of what I was going to cover has been covered very well by some of the previous speakers. So I'm going to cover this in a little bit different way than was probably anticipated, in the fact that when I introduce intravenous vitamin C to my colleagues, they always have tremendous objections. And this is because the word on the street of the regular medical oncologist, radiation oncologist, doesn't cover what we know for intravenous vitamin C. So, and it has to do with differing perspectives. Now, on this, if you squint your eyes, you may see a different person than the other. You may see either an Albert Einstein, or you may see Marilyn Monroe. So it sort of depends on what you anticipate finding. Also may help set your ideas about what can and cannot be done. So the word on the street is that vitamin C blocks chemotherapy by preventing free radical cytotoxicity. And they would say that this may help reduce side effects, but at the cost that it decreases effectiveness of chemotherapy and radiation. They would also say that vitamin C has no anti-cancer effect of its own. They would also include vitamin C blocks cancer cell apoptosis by decreasing mitochondrial injury signaling. And they would say things like, well, vitamin C, it causes kidney stones, decreased kidney function, and it creates expensive urine, and it's far too toxic. Well, I gave chemotherapy as an internist from 1976 through 83, where every patient had to be in the hospitals before the anti-nausea drugs. We had to hydrate them, and everyone was in serious infection, and we were always requiring infectious disease to help us out in controlling their infections. And to me, that's a tad more toxic than what vitamin C is. But if you were going to go and put a combined modality therapy together, the four parameters that are usually used is that each individual modality has to have effectiveness. And they would like that to show that it has partial responses, at least 20 to 30% or more, and complete responses of around 1 to 2%. In addition, the mechanism of actions of one should not interfere with the other. They will sometimes choose, and the reason for doing this is that they get a better tumor response. And in the safety profile, they will choose each modality so its primary toxicity area is not matched by another one in the protocol. And in addition to that, they want a metabolic match, and so that the detoxification of these chemotherapy drugs aren't interfered with one of the other ones in the regimen. So, and I apologize, this is fairly simplistic. I didn't know who my audience was going to be, but ways of determining effectiveness are fairly straightforward. Partial response being a 50% decrease in the size of the tumor, or more. Complete response is no measurable tumor. Stabilization is no progression, and that means less than 25% larger tumor by measurement on diagnostic x-rays. bar some of the tried and true things are improved overall survival, time to first relapse, palliation, and they would hope that they would occur in at least 20 to 30% of patients, and no evidence of progression, which is greater than 25% increase in the size of the tumor. Well, if we were to compare this for standard therapies, these are mixed. Phase 1 is the safety or toxicity, and they would say that we have very good studies showing all this, and they would say that there aren't studies as far as vitamin C is concerned. However, it just goes to show that they have not read the literature. And granted, a lot of the studies that look at this have been studies that have looked at oral administration, but we do have obviously studies which have gone through here that show that IV administration of vitamin C is definitely safe. And many of these articles have been previously discussed, so I'll just run through this, and if anybody has a full bladder, we'll get done maybe a little early for you. So Charles Simone is a medical doctor. He's both a medical oncologist and radiation oncologist, and he did a literature search from 1965 to 2003 and found 280 peer-reviewed articles, 62 in vitro and 218 in vivo, 50 human studies, both randomized and observational. And out of this, 8,500 patients he found that had been treated with antioxidants, including ascorbic acid. And the overwhelming conclusion was here that they do not interfere with the effects of either chemotherapy or radiation. In fact, there was a tendency toward enhancing the killing effect. And in 3,738 of these, they had improved survival. So, I mean, this is a Medline search, but it really speaks for the fact that there's no interaction that would necessarily block the basis by which chemotherapy and radiation work. So the next area that we would look at is mechanisms of action. And most chemotherapy, many of those drugs do form free radicals that cause the cytotoxicity. And in addition, radiation therapy will also do this. Now, if you have conventional radiation, which is 1 million volt up to 18 million volt X-rays, 90% of the effect of that radiation will be by forming free radicals, primarily the hydroxyl ion. But if you get to things like proton or neutron radiation, which is not very commonly used because it's really expensive to make those machines, but then 90% of its action will be due to double-strand breaking of DNA. And so those are the two mechanisms, but conventional radiation therapy would be primarily active by forming free radicals. And of course, cell cycle toxins prevent division. If cancer cells aren't dividing, then they're certainly much less likely to be a problem. We've had previous speakers talk about anti-angiogenic effects and apoptosis. And if we were going to look at apoptosis, we want apoptosis to occur in the cancer cells. We don't want it to occur in normal cells, because one of the processes of direct invasion is thought to be due to a lower pH, a higher acid content of the cancer tissue, which then prematurely induces apoptosis by external signal in the normal tissue. And this is one of the ways that normal tissue breaks down and allows for invasion. And then as if you have redifferentiation, I think part of this is really from spontaneous recovery, but there are definite times recorded where treating with chemotherapy caused regression, and then all of a sudden when they reviewed the remaining cells that were cancer cells, they looked like they had actually reverted back to normal. So those are the mechanisms of action, and they choose chemotherapy, like I mentioned, most of them will have one major form, maybe a minor form of mechanism of action, and they will typically choose modalities that have different primary modalities of action in order to improve the tumor response. Now, if you can compare this, I don't have anything listed under the chemotherapy part. However, usually the toxicities or the process, as mentioned, is one primary way of doing this. Mostly it's free radical formation as far as the chemotherapy is concerned. But they have been looking at others. Adriamycin, for instance, primarily is that, but in lower doses, it can also have an anti-angiogenic effect.
Excuse me,
Yep.
what's CMT mean?
Combined modality therapy. Okay. With intravenous vitamin C, we know that at higher doses it makes the hydrogen peroxide, which creates free radicals, so it can cause cell death that way. It too can be a cell cycle toxin with that. We've just heard about the anti-angiogenic effects of this, and in apoptosis, even if high-dose ascorbic acid doesn't directly create apoptosis, although some people think it may, it sets an environment for this to happen. By that I mean there are three things that typically need to be present for apoptosis to occur. One of them is non-mutated P53, another one is an intact immune system, and a third would be creating an environment that would allow the mitochondria to revert from anaerobic glycolysis back to aerobic so that we get the higher ATP formation. If you have those three things intact, then it's possible to induce apoptosis in the cancer cells. Well, as we know, the immune system probably wasn't working perfectly for the cancer to develop, and chemotherapy has been known to, at least on occasion, cause a decrease in the immune system's action. And now we want this weaker immune system to be able to come back and help out, and that's not very likely. As far as anti-invasion also, we know that vitamin C creates collagen, and it may help prevent direct invasion from that by that process. And it helps decrease further mutations in cancer tissue. Therefore, hopefully we would still have some non-mutated P53 that could help induce holding the division phases long enough through protein 16 also, so that actually correction of the mutation can occur. So how about safety profile? That's third one. And because of the toxicities of chemotherapy and radiation, they have used cytoprotectants. And commonly used ones are amifostine. A lot of this is head and neck cancers, Mesna, and dexamethasone. But we also know that vitamin C, either taken orally or by intravenous vitamin C, can have a cytoprotectant effect. And if you look at cytotoxic potentiators, amifostine also is supposed to be able to do this. And we know the other side of the vitamin C is that because in high enough doses, it forms free radicals and therefore can be a cytotoxic potentiator. Okay. The real thing here, though, the most important thing is to remember that vitamin C works differently in normal cells and then in cancer tissue. And with this, it works mainly as an antioxidant in normal tissue, even at the higher levels, and that's because most cancer tissue is depleted in catalase, and so it has a more targeted effect on the cancer tissue. The safety profile, and Dr. Jackson spoke to this, the glucose 6-phosphate dehydrogen deficiency. We check for that. If that's not present, which usually it's not deficient in most of the patients we see, then that's not a problem. I think it was Dr. Gonzalez who talked about renal stones, and that's important. He was mentioning the study by Curhan, where there were 85,500 patients approximately followed for 14 years in patients that were taking 1.5 grams of vitamin C a day and had no increase incidence of renal stones. The other reason this probably happens, which I don't think was mentioned, is that vitamin C has an antibacterial effect, and it's the nidus of the bacterium that serves as a source for the collation of the mineral to form a stone. If we are cognizant of IV fluid tolerances and we have to decrease the rate of our administration of our IV vitamin C, if a person has congestive heart failure, we might not be able to do it at all, or if they have renal insufficiency. These two things certainly are also for chemotherapy. Radiation therapy isn't as much affected by this. And if to decrease osmolality problems from infusion, we try to keep the osmolality at around 870 to 920, and all of the solutions that we mix up on the protocol are within that, and typically we give it at 60 drops per minute for a safe infusion. So this is just a functional status that we use and oncologists commonly will use this to determine if the patient's well enough to receive chemotherapy. And if we get down to around the 40% on the Karnofsky score, then it's possible that they have decreased function enough in enough biological systems that they won't be able to tolerate. However, intravenous vitamin C can still be, in many cases, if not most, be able to be used as a standalone therapy with this. So it is possible, because we cause far less decrease in functional status than standard chemotherapy, that intravenous vitamin C may be used in patients with less good function.
What is ECOG stand?
That's an Eastern Cancer Oncology Group. It's also called the EBROD scale. So if we compare toxicity protocols for chemotherapy versus intravenous vitamin C, chemotherapy will almost always cause some decrease in function of some organ, and it has increased organ toxicity listed. Cytotoxicity progenitor, yes, it can be, but in chemotherapy it affects all tissues, normal and cancer tissue, where that is not true for the intravenous vitamin C. So very minimal toxicity for vitamin C. And if we go to information for a metabolic match, this is, we're looking at, yes, if we give low-dose antioxidants, Kedar Prasad would tell us that, especially in the ones they say, well, just take one multivitamin that has some vitamin C and a few other antioxidants, you may actually stimulate a very low level of hydrogen peroxide, which is a potential proliferating agent. If you get that level higher, then it serves as a cytoreductive agent. So the conflicting things, and my colleagues will always remember the things that didn't turn out well for any antioxidant therapy. They'll say your own research people, Kedar Prasad was with the University of Colorado in Denver, has published 45 articles on chemotherapy, radiation, and the effects of antioxidants, including vitamin C. And his work shows that if given in the proper amounts, given before chemotherapy, during chemotherapy, and after, then you will not see this preliminary cell proliferation. So the other thing is that in development, preventing resistance with the intravenous vitamin C, you have the chance of decreasing further mutations. There are people who have actually calculated the number of potential mutations in cancer cells, and depending on the particular match, there'll be anywhere from 40 to 140,000 different mutations that can occur. So it's a wonder that any kind of even combined modality therapy has a specific effect for any organ-specific cancer. But that's why you have to have some toxicity that's pretty good in the cancer in order to get ahead of that. So, but Kenneth Conklin out of UCLA, who's had 30 years of experience using antioxidants, he's a PhD in pharmacology, and he's an anesthesiologist by formal training, but has worked with their oncology unit and has given antioxidants a number of different forms. And he feels that one of the reasons that chemotherapy can be given in longer term is because it helps decrease the potential risk of developing resistance. So, metabolic match also, as far as does vitamin C or antioxidants change the ability for chemotherapy to do its work. Some chemotherapy agents, the metabolic, the first through first pass metabolite is actually the most active agent, and this is true of several of the chemotherapy agents. And if we altered that, wouldn't that cause a change? Well, in the effectiveness of the chemotherapy. Well, I've never seen any medical oncologist measure phase 1 and phase 2 changes, and granted, being its antioxidant activity, you could theorize it is potential. But Jeffrey Bland's work at looking at phase 1 detoxification, antioxidants primarily would change phase 1. 50% of the population has fast phase 1 and fast phase 2. So, excuse me. So you wouldn't change that. I think I might need a little water. And if you're like 35% of the population, slow versus fast, you would improve. I have to wait.
You're getting it, Blake.
Okay. These two. Ron, you have any good jokes? No, we know you don't.
Bad jokes.
Any joke will do.
I think water would be better. But yes. Natural remedy. Thank you. Well, 35% of the population has the slow fast, and this would improve the effectiveness of the chemotherapy that had to have a first pass through the liver. But would it really change how we approach the cancer patient as far as chemotherapy? Because they don't measure these parameters to see, basically one of the major guidelines that they use is what the white blood count does. If it doesn't go down as far as they think they can push it and still be safe, they'll give more chemotherapy on the second cycle. And if it goes down too far, they give less chemotherapy on the second cycle. And for the population that has 15% is only of the total population, they have a slow rate here. And like I say, this has not been something that's really measured by medical oncologists, and therefore I don't think really would be a factor. But I've had medical oncologists say, well, antioxidants change that, and because some of our chemotherapy requires the first metabolite for its effectiveness, we shouldn't use any antioxidants when giving chemotherapy. The other thing is it is potentially possible that antioxidants would help decrease the hepatotoxicity from chemotherapy, and that can be a limiting step. If your liver enzymes go up, the ability to give chemotherapy full dose goes down. So, does intravenous vitamin C interfere with the chemotherapy radiation that have free radical formation? To me, I would say no, because in the higher doses, it too causes free radical formation in the cancer tissue, but acts more as an antioxidant in the normal tissue. This is a listing, I don't know why this was better on the initial thing, but all these are supposed to be in the same. This is a list of 13 chemotherapy agents that their primary mode of action is by producing free radicals. People have asked me for that list. Remember, this is from Alternative Therapy Review. Okay. Now, literature opposing the use of vitamin C, and this has been mentioned before. Dr. David Gold, I've heard pronounced Goldie too, I don't know which is correct, has said that antioxidants interfere with free radicals. That's true. We covered that already. Because of the experiment that they did where they were looking at vitamin C uptake in tumor, that it was 5 or times greater than in normal cells. Well, it's the same process for PET scans. It's a fluorinated glucose molecule. Because cancer cells have many more, the biochemical looking at where the cancer tissue is with a CT anatomical background will show you where fewer cancer cells are than by just normal CT alone. And the same process actually works for vitamin C because of using GLUT receptors. Out of the University of North Carolina, Dr. Selgagnik says that patients on chemotherapy should receive diets totally devoid of antioxidants. What do you eat? I mean, just about all food has antioxidants in it. And if you did that, the change in the 150,000 biochemical processes that occur every second in the body would be dramatically altered. So if you really want sick patients, don't give them nutrition during the time of their therapy. Vitamin C interferes with mitochondrial depolarization, and Dr. Mark Heaney, this is from Sloan Kettering Memorial, did a study where he had cancer cells growing, and he treated them with dihydroascorbic acid and in the culture, and after that had a chance to mix for a while. He then transferred those cancer cells to live, I think it was rats, and then they gave chemotherapy and that looked to see what the cell kill was. The more dihydroascorbate that they used, the greater decrease in cell kill. Well, I question about this. This isn't the way we give chemotherapy. I mean, we don't give it to a cell culture. We give it to the person receiving the therapy. And if it is true that change from ascorbate to dihydroascorbate is one of the initiating things for causing several biochemical reactions that lead to the formation of hydrogen peroxide, then we would be deleting the ability of that tissue to have the hydrogen peroxide, which is one of the major ways that that vitamin C does its work also. So I don't think this proves that the way we give vitamin C therapy decreases the effect of adriamycin, cisplatin, vincristine, methotrexate, or Gleevec. So I don't think that that should hold up as far as a reason we should not use antioxidants or vitamin C. Further, and this was mentioned also, I think, by Dr. Michael Gonzalez. I was at Mayo when one of these studies was done. And despite the fact that Linus Pauling had strongly encouraged them to give intravenous vitamin C, they chose not. I have no idea why that was. And when Linus Pauling asked for their data, they declined that opportunity to have it reviewed. And when Ed Cregan was asked about this and if we were to do other studies regarding intravenous vitamin C, he said that there were some design flaws in those original papers and that he would be willing to serve as a review person for study of intravenous vitamin C. To my knowledge, that hasn't come about, but at least he was willing to do that. The vitamin C has no benefit in prevention of recurrence of stage 2 breast cancer. This was out of British Columbia, the Les Prince study. And really, this was for matched controls with this. There was a tendency for the treated group with vitamin C to have a higher recurrence rate. Well, when we went back and looked at the data, these patients, even on stage 2, many of them chose not to have radiation therapy as part of their original treatment. And we know from Dr. Fisher's data that if you take out a tumor, even if you have margin, radiation therapy to the initial tumor site decreases the recurrence rate from 28% down to about 7%. So that may explain the mild difference, suggesting that vitamin C had no benefit. And there was a review article by Dr. Gabriela D'Andrea, and this is a more recent review, but again, she uses a lot of prevention data and taking data from one thing that and saying that was a reason that antioxidants shouldn't be used, and it really didn't have a means of truly, honestly supporting why antioxidants should be used. The best defense against this that I've read was that of Dr. Ralph Moss. He took this review article by Dr. DeAndrea and went through every little piece of it and just very well explains why her review article was not justified. So, I can guess that by my tone you can guess that is vitamin C down for the count because of its supposedly blocks the cytotoxicity of chemotherapy or prevents signaling of apoptosis? I don't think so. And literature suggesting use of antioxidants and vitamin C, well, where do we find this? We have approved by the FDA cytoprotectants called amifostine, dexrazosane, and mesna. And how do these things work? They are antioxidants. And they're claimed to increase the toxicity of the chemotherapy so it has a better effect while protecting the normal tissue. So here are 3 examples of synthetic antioxidants that are approved by the FDA, but lo and behold, don't use a natural one. So literature is suggesting antioxidants do not obstruct things. A really good review from Davis Lamson, and this was, I believe, also an alternative therapy review. There were 2 articles that followed each other, and they specifically looked at vitamin C in 3 of 91 articles. And they had the same conclusion from these articles that Kedar Prasad had, was that low-dose antioxidants given only once before you start regular chemotherapy or radiation, that potentially could be of a problem. But if you used exogenous antioxidants, meaning antioxidants not made in the body, and you pre-treat them, according to Kedar Prasad, at least 1 to 2 weeks before, during the course of therapy, and for 1 to 2 weeks after minimum, then you will actually see enhanced cytotoxicity and decreased toxicity of normal tissue. So, and there was a good study out of Finland, Dr. Jakolak, and that showed that use of oral antioxidants, meaning vitamin C, with cisplatin in the treatment of small cell lung cancer actually improved the response, and that was in terms of about 20% better response. And that did correlate with longer-term survival, but that difference wasn't huge. And then Jeannie Driscoll from University of Kansas Medical School, the 2 cases she has, and plus I know she's doing a lot of other intravenous vitamin C, that showed that it didn't interfere with the chemotherapy adriamycin for ovarian cancer, and that's a very tough cancer to try to get ahead of. So that's some of the literature that supports this. Well, how do we get to this impasse, basically? Well, the people that are on the side saying you shouldn't use antioxidants, they believe that the only function of antioxidants is to destroy free radicals, and that it protects normal tissue and cancer tissue equally, and that antioxidants do not limit the growth of cancer cells. And so if you have this mental set before you start, it's hard to accept what the literature actually better supports. And that maybe exogenous antioxidants may interfere, but if you're looking at vitamin C, which I was supposed to speak to, and other exogenous ones, they do not block the effect. High doses are important because low dose, very low dose, actually can cause cell proliferation. And high dose antioxidants also will enhance the effect of the radiation. And the head and neck cancers with cisplatin and vitamin C would do well, as with the typical one that they use, amifostine antioxidant. So, and again, just to stress the importance, you have to start early and make sure that you have a good antioxidant dose on board. And mixture, this from Kedar Prasad also, if you have more than one antioxidant working, that will help with both the potentiation of cytotoxicity and decrease of side effects. His warning is that endogenous glutathione and coenzyme Q10 might have a little increased risk of causing problems with chemotherapy and radiation, but I know there are a number of other investigators that would suggest that that's not true. So, again, well, great minds run together, I guess, so the people from Puerto Rico, thank you. If you wanted to have a perfect anti-cancer therapy, these are some of the things that you'd want it to do. It would be cytotoxic, anti-proliferative, anti-angiogenic. You want it apoptotic as far as normal tissue, so you don't get invasion, but you want it pro-apoptotic in cancer tissue. You want something that would decrease resistance. You want to help redifferentiate the tumor. You want to decrease the risk for secondary cancers, improve normal tissue repair. Antioxidants, one thing I didn't mention before was that they tend to be vasodilators of normal tissue that helps increase the distribution of your chemotherapy. And that can be a problem, especially for chemotherapy that doesn't cross the blood-brain barrier. And vitamin C does cross the blood-brain barrier. We see that pituitary is one of the highest concentrations of vitamin C that there is. And so if you look at that, then vitamin C really enhances the effect of chemotherapy and radiation because of those things I just mentioned. And I just threw this in. I already mentioned this slide, so I'll go past this. But one note from this is that chemotherapy tends to kill, as does radiation, a certain percentage of the growth fraction of the solid tumor. And only a certain percentage are dividing at that time. That's the growth fraction. So theoretically, by mathematics, you cannot kill the last cell, whether you give chemotherapy or radiation. There will be some that remain. And they say, well, then when you get the number down to a very small number, that the immune system will come to the rescue and take care of those cancer cells. However, we have just beat the ever-living daylights out of that immune system by giving surgery, radiation, or chemotherapy, and now we want a weakened immune system to do the job, and that's just not likely. So with that, the paradigm, over the last 60 years, we basically had biochemical warfare against cancer. This war was declared in 1971 by Richard Nixon. And we have really, truly pushed the killing power of chemotherapy to its max. We went from single agent, combined modality therapy, to dose-dense chemotherapy, giving as much as we could, as frequently as we could. And the only reason they were able to do that is by colony-stimulating factors and bone marrow transplants. But we have reached the plateau. There are no further gains. We already have a scorched host approach, and it just can't go any further. So at the ASCO meetings, I didn't attend the last one, but I am told that some of the powers that be there suggest that we need a new paradigm. Thank you. I believe that to be true. That low-dose maintenance long-term chemotherapy may have better effect because of some of the other properties that it may have, like anti-angiogenesis, cell signaling inhibitor effects, and targeting for cancer cells. I salute this, and I think vitamin C would be a great thing to be compatible and combined with that. So is IVC compatible with chemotherapy and radiation? I would say resoundingly yes. In fact, it could be the poster child molecule for compatibility. And I agree with Ralph Moss that we definitely need the clinical trials to prove this, and we need the funding to make it happen. Thank you.
That's great. That's great. Okay, if there are any questions, would you please come up and just talk with Dr. Hyland or Nina or Dr. Kasari? Yeah, that's good. Then and Dr. Jackson. But otherwise, I think doesn't everyone need a break now? It's such a beautiful day out there. I just
want to describe this.
Oh, one last slide.
Okay,
Yeah.
don't forget it.
This is actually a chalk drawing on the pavement, and if you pass by it and have a perspective, it'll actually look three-dimensional. But it's really flat. So what I was trying to change poverty into cancer history, but I couldn't get that done, and my computer skills aren't that good. But I thought if we change our view from the Earth is flat to a global view where we get people's opinion from around the world how to use good nutrition, that we certainly can make cancer treatment history, if not even make cancer history.
Thank you.
Yes, I have one question for you. Since you are a radiation oncologist, we get a lot of patients, cancer patients, post-radiation. And how safe it is to give high-dose vitamin C after radiation?
After radiation?
Yes.
I think it would be fine.
They come with like 1 million units, as you mentioned, or 2 million units of radiation. How soon can they have intravenous vitamin C?
Well, I would like to see it be given just about every day. And the reason for that is that the thing that improves the effect of radiation on cancer cells versus normal cells is that you have some that will, normal cells that will have sublethal damage. And so you want something that will promote the healing of that normal tissue, because it's the difference between the normal tissue and the cancer tissue effect that really is where what you're looking for a response of the tumor. So from that point, you want to have things on board that will help in that healing of the sublethal damaged tissue.
Thank you.
Let's take a break. Thanks, everyone.
The first annual Riordan IVC and Cancer Symposium was brought to you by the Center for the Improvement of Human Functioning International, located at 3100 North Hillside, Wichita, Kansas, USA. To learn more about the center and what we have to offer, please visit us on the web at www.brightspot.org.